Now, I had been given, all right, maybe I did come up with this, right? From Haiti to Rwanda, structural violence. But saying it to a crowd like this, which includes several friends of mine who are in the social sciences relevant to medicine, saying context matters is hardly a bold proposition. I don't think that anyone here would disagree that context matters. How it matters is a different issue, and I'll go into this. One of these images is from right after the genocide, and another one from after the earthquake in Haiti. I've already had a chance to speak about the earthquake here. So I'm going to go on to something I haven't had a chance to speak about, which is public health fundamentalism reflecting on the Ebola epidemic, or this particular recent, and think about what that means to have zero vision, to exclude not only social medicine, but also equity from the discussion. Let me just begin by illustrating. Just a little bit of background. Some people here know far more about this than I do. Although I must say, one of my books from 15 years ago, Infections and Inequalities, has a picture of Ebola on the cover, a mass grave. And it never did well, and my publisher at the University of California said, you shouldn't have dead people on the cover of a book, it's not good for sales. And so I knew something about it, but not the way I was going to learn about it through this experience that I'll describe here. But just in terms of background, Ebola was, the word we throw around is discovered in 1976. Of course, that just means that the technology for identification of a pathogen like this finally overlapped, as it had in Europe some decades before, overlapped with the pathogen. The story of this is a very sad story. It's related to social medicine, as everything is. But just to speed up the narrative a bit, what happened was, this is a nosocomial epidemic that afflicts predominantly caregivers. Again, a lot of confusion about this, and I'll go back to the confusion, which has been propelled by public health fundamentalism and health behaviorist thinking, cognitivist reductionism. But what happened in 1976 was that, and some of you may know this story directly from some of the folks who identified this virus, in a mission hospital, short stories in a mission hospital, the disease is introduced, spreads rapidly from person to person, afflicting largely caregivers. That was the story in 1976, is the story today. Now, how does equity come in? Well, the pathogenesis was propagated by substandard medical care. I said a mission hospital. This is in what's now the DRC in the Congo. The hospital had about 100 beds, but it had no doctors. Now, how many of you would go to a hospital in Oslo with 100 beds and no physician? I think nobody. And it was run by very well-meaning, I have no doubt, sisters from Belgium, Flemish speakers. And they were reusing in their clinics, inpatient and in their outpatient clinics, they were reusing needles, vaccination needles, in an effort to save money, to be reflecting their own virtues of prudence and caution and reserve. And of course, that's not a wise way to advance such virtues, and they don't become virtues in a setting like this. And this rapidly spread from person to person, amplified by substandard medical practices. In 1976, substandard medical practices. You wouldn't have been able to do that in Belgium. And of course, that was a very unpleasant thing to have to explain to the sisters, several of whom died, as did a physician summoned in from another district and the priests who were working there. And one of the people who shared this story with them is Peter Piot, when he was a young man in Antwerp, training in infectious disease, as I was, and many of you know him through his work on AIDS. But the story that he tells in his memoir is much more up close and personal. How do you understand the epidemic? And also, how do you explain it? to others. Now these are just three images to remind us of the importance of zoonoses. The first is Marburg. It's a very similar story. It has that German name, as some of you no doubt know, because it was discovered in a place where it could be discovered. That is to say, a laboratory. This was not a research laboratory. It was a laboratory for the production of polio vaccine. African green monkeys were being sent to Europe for the production of the vaccine, and it spread rapidly from infected monkeys to lab workers, and then all the way to another German city and to Belgrade through that same chain. So understanding these events, which are transnational, that is to say global, and connected in very important ways to disparities, could not be done without social medicine, I would argue. And nor can the current epidemic, or the recent one. Now, here's part of the problem I'll get to first. Many people in this university have count their globe as larger than Oslo, Norway, Scandinavia, Europe. And for those of you, which this includes many of, certainly my friends who are here today, many of you understand that diagnosis of anyone with a fever, let's say, that the cardinal symptoms of Ebola are fever, diarrhea, and vomiting. Right? So a patient comes in, say you're in Malawi, or in Sierra Leone, or Liberia, or Guinea, and a patient comes in with a fever, or fever, nausea, vomiting, diarrhea. Again, for the physicians who practice, and not just in places like where I was yesterday and will be tomorrow, but anywhere, the differential diagnosis is broad, and it also requires staff and stuff and space and systems, and I'll return to what I mean by that. So what do? You have a patient who comes in with these symptoms. Without laboratory capacity, which again, all medicine is social medicine, and so people practicing it need to understand, and if they can find someone else to worry about how to build a lab, great. When my colleagues at Harvard, at the Brigham and Women's Hospital, the surgeons complain, as they often do to infectious disease doctors, because we're good listeners. When they complain, I say, at least you don't have to build your own operating room and put in the electricity. And most of the time they don't get what I mean, or at least they used to pretend they don't, but they understand. If someone else can worry about having diagnostic capacity, great. But otherwise you're stuck with this long list of possibilities, and that is what happened in 1976, and it's what happened, alas, in 2013, when this current outbreak began. By the way, one of the things that you heard again and again in Norway as elsewhere was that this is the first time that there has ever been Ebola in West Africa, or this part of West Africa. But all you have to do to think that that might not be true is actually look in the medical literature and find surveys, serological surveys, from Liberia and Sierra Leone at least, if not Guinea, showing that Ebola was indeed present. It's just that we forget so quickly. Right? And it's okay, you can keep repeating it again and again, errors of whatever sort you like, right? Because without social medicine, which includes a historical approach, no one's going to say, well, gee, that's a colossal error. If it involves poor people, all too often, just gets shrugged off. So this story, I'm going to just tell you how I experienced it. I had actually never been to Sierra Leone until the summer of 2014. I was working on another Lancet commission at that time, and with surgeons. I brought up surgeons already just by accident, but we were working on, and there were colleagues from Norway as well, we were working on surgical care in settings of poverty. These days we just call them resource poor settings, which is again, when I hear that term in Boston, I say, well, Boston's a resource poor setting over in that neighborhood. That's what social medicine reminds us. But I had not been there, and the first meeting there were 3 meetings in these Lancet commissions, as you know. The first one was at Harvard Medical School, and the third one was in Dubai. Go ahead. I was hoping people would at least laugh. These are great places to have meetings, don't get me wrong, but I was on the commission, and in fact, if I could say it in a modest way, I'd raised the money for these meetings. And since it's all about power, as you pointed out, I had the power to change that, which is kind of a good feeling. And I said, we really can't have the first meeting at Harvard, the third one in Dubai, and not have a meeting somewhere that is actually resource poor by every convention. And we ended up going to Sierra Leone for that second meeting because of some colleagues from England particularly, but because we wanted to have one of these meetings in a place that is a clinical desert. Right? It's a clinical desert, which is why Ebola killed, and it's a public health desert, which is why it spread. Now, having helped to marshal the funds for this, I can tell you, I had been following, in fact, I've been trying for 30 years to get off that ProMed, or whenever they started it, where they're sending out bulletins about every rare outbreak. I still don't know how to unsubscribe. If some young Norwegian technocrat could show me, I'd be glad. But on this particular instance, I'm kidding, I don't want to get off ProMed. I'm just trying to make you chuckle. In this particular instance, anybody on that list, and infectious disease doctors in general, started hearing about this outbreak in March. It had begun, it's thought, in December of 2013. Oops, what am I doing? I'm ruining my own talk, because it's supposed to please Per as well. So I began receiving news of this between Harvard and Rwanda, and I had some pressure to change the venue, because in March it was clear that the Ghanaian deaths had been caused by Ebola. It was confirmed, and it was marching west from a place that some people call the Tri-Zone area, a small patch of land where Liberia, Sierra Leone, and Guinea come together. In a little island only 20 miles or so across. They all come right together. So if you look at the map, which I hadn't done very often until recently, that was held to be the epicenter or the beginnings of the epidemic. So of course it had spread across those borders to Liberia and Sierra Leone. There really is no borders. These are crossed by footpaths. These are colonial inventions, I'll return to that in a second, from the late 19th century. Liberia's borders had been disputed for longer than that, but really these are European creations, and Liberia is a creation of American settlers, American colonists. And there was, for people who knew the region, which as I said, I did not, there was no reason to believe that it would not spread across those borders, and it promptly did. By April or May of 2014, again, I was receiving some pressure to find another venue, because it was not safe. It was claimed to have a meeting in Freetown, the capital of Sierra Leone. Well, I objected that Ebola was not spread through medical conferences, but rather from a lack of staff, space, and systems necessary to prevent its human-to-human transmission in clinical settings. So we didn't change it. And in this June of 2014, I made my first trip ever to that country, and I knew exactly three people, Sierra Leoneans, not counting a new commissioner from the Lancet Commission, who hosted the meeting in many ways. One of them, all three were doctors. One of them was a student of mine, Byler Berry, who I'd known over the course of the better part of a decade. He had started a small non-governmental organization in eastern Sierra Leone, although that's not where he was from. His name was Byler Berry, is Byler Berry. The one in the middle, Martin Salia, a young surgeon, had been in exile after the war, first in Guinea and then in the United States, but always wanted to go back. He said, I became a surgeon so that I could serve the poor. And he attended this meeting. And then the third, an infectious disease colleague named Humar Khan, who was very well known in those circles, in our small circles, because he was an expert on hemorrhagic fevers, particularly on Lassa, but also on Ebola. He, if fate had been kinder, was to spend the last academic year at Harvard, 2015, 2016. Now, that was June, and by November, 2 of them were dead of Ebola. And if you remember, and I'm sure this happened in Europe as well, is to remind us of, again, public health fundamentalism in one of its forms, which is a focus on risk, except they got the risk wrong. You see the cover of Newsweek with a bushmeat. I've already said, this is a zoonosis, so it requires a spillover event from another species. We're not even sure which one. Ebola is not, the host species is definitely not a chimpanzee, because they're sickened also by this virus, all primates it seems. But the focus on bushmeat, on primitive behaviors, and these were out there in the press for months, and maybe they still are, was very striking. And yet we knew this was spread person to person through inferior quality medical care without the staff, stuff, space, and systems required to halt it. We knew that since 1976. So essentially, as then and now, this caregiver's disease began picking off those who put themselves, these health professionals who put themselves between poor patients facing long-standing risks of epidemics and death, right? Because the idea that this was an untreatable illness could not be sustained by anyone with any clinical knowledge. The main symptoms being, as I said, fever, diarrhea, vomiting. Now, it seems to me that in Norway or in the United States, for 100 years, we've known how to treat massive fluid loss, which is by what, at least in the United States, used to be called replacement therapy. You replace the fluids and the electrolytes. That's what happens when you get the flu and go to an emergency room in Oslo, or your child has another bout of diarrheal disease. But the public health fundamentalists not only got the risk factors incorrectly, but the clinical management. And if you were from this part of the world, which I obviously am not, you would have recognized this as a very familiar approach. And you might as well call it the control without care approach. And that's part of the public health fundamentalism that Per has spent some time critiquing. And the difficult part of this was that managing risk was really managing risk for poor people or the rest of us. And I'll lay this out in detail. Now, Humar Khan, by the way, was the first to die. He died on July 29th. I left on the 22nd of June. And on the last day there, I was with my wife actually, I was headed back to Rwanda. And I was asked to go visit 2 clinical facilities. One was set up in the main referral hospital, colonial relic called Connaught. It was an Ebola treatment unit. That was what it was. I knew the lingo a little bit, the acronyms ETU. They were just opening it and wanted me to come and inspect it. These were friends of mine, including some English physicians and a Spanish infectious disease doctor and 3 Sierra Leonean nurses. The other institution was also founded by Europeans. It was an it was an Italian group that was focusing on trauma care. Now, I had met with the English folks before at Harvard in the Department of Social Medicine and said, if you're going to go to Sierra Leone, then you should find a way to work with the public sector, right? How un-American is that, by the way? You guys get to feel very superior because of 100 years of investment in public health in the public sector. But I had to learn this the hard way as an American. And they did, and that's how they end up in Connaught. And I left there thinking, first of all, went in, the entrance to this unit was through the emergency ward. And they knew as well as I did that was not a good idea. And it was tiny. It was 6 beds. I have to go back and figure out if it was really 6 or 8, but it was a tiny little unit. And it had beds, buckets, and plastic sheets, And I was thinking, what is this going to be like when there's chlorine, vomit, and shit all over the place? How could you possibly protect yourself, right? They're sitting ducks. And that is what happened to Humar Khan, right? Humar Khan, this is the world's only Lassa unit, for treating Lassa. This is a famous personage who has received funding from the National Institutes for Health, the World Health Organization, the Centers for Disease Control. I told you already his connections to Harvard, Tulane, but that was for research. And as the rector said, you can't do research without thinking about service delivery and training. And he knew this very well, that he had a great research project, but a disastrous clinical facility. So again, without the staff, space, or systems, there was no way that those nurses and Umar Khan were not at risk. And indeed, it did not take them long to fall. Right? By that day that I went there in June, it was clear that Ebola was already in Freetown, and it had already made that western surge from those forested regions in the east to the great cities of the Atlantic. And I say great cities, I mean Conakry, Freetown, Monrovia. Great in what way? They were the epicenter of the slave trade. This was the epicenter of the Atlantic world, right, which connected that part of Africa to Europe, South America, North America. Indeed, the argument has been made, I think quite compellingly, that that is how we constructed the Atlantic world. That the great cities of France, Bordeaux, of the Americas, Charleston, Boston, all the way up and down the coast, Brazil, the Caribbean. There's a link to West Africa in a very intimate way over the last few hundred years. Now imagine saying that in the middle of rounds at a teaching hospital. I'm not willing to do that, actually. That's another best-selling book of mine, Women, Poverty, and AIDS. Good subtitle, though, Sex, Drugs, and Structural Violence. Nobody read it except for my mother. Uni Wicon read it. Anyway, this is the social medicine perspective, thus includes knowledge of staff, space, and systems required to prevent or halt an epidemic, but also to understand where did this come from and where is it going. Now, it was clear to anyone willing to look, certainly by July when Umar Khan died, this was international news. The focus, interestingly, was not on a lack of staff, space, or systems. It was on the use of an experimental drug or agent called ZMapp. And that's a sad story as well. He ended up not getting the only doses in the world. And where were they sitting? They were manufactured, I think, by a Canadian firm. And where were they sitting? They were sitting right where he lay dying, in the middle of this forested, semi-forested region already razed by war. Why were they there? Well, they were left there in a refrigerator to see if they were heat stable, right? And evidently he was not, this is a difficult subject for me having known him, evidently he was not consulted on whether or not he should receive that, but they decided, those taking care of them, some from the world's largest humanitarian agency, medical humanitarian agency, and the others from the largest regulatory body on health in the world, or maybe not the largest one, but the most important one for standard setting. They decided no, he would not receive this therapy. So it went by plane to 2 American missionaries in Liberia, both of whom survived. Now they did survive, in my view, because they received this experimental agent, ZMapp. They survived because they received replacement therapy, but not in West Africa. They were flown in a biocontainment plane to Atlanta, where they went to Emory University Hospital because there was a biocontainment facility there. Friends of mine, in fact, some of my trainees are infectious disease doctors there, and they received, as is necessary, massive replacement therapy. Sometimes people are losing 10 liters a day with this disease. And even the most ardent chuggers of Pedialyte, I don't know, is Pedialyte an international brand? Oral rehydration salts? Right. Anybody here, do Norwegians still have children? So if you have children or a pediatrician, you know how hard it is to get kids to drink oral rehydration salts, right? Well, imagine you're an adult, but you're throwing up. How on earth can you keep it down, right? And this, as I said, is one of the 3 main symptoms. And you can imagine what these places look like within a few days of having patients in them. Filthy and swimming with billions and billions of copies of this virus. And of course Umar Khan got sick, and of course half the nursing staff died, right? It's a public health desert. What are we going to do? It's not cost effective, not sustainable, not... They don't do that. They just put a hospital, one day it's not there and the next day it's there. I tell you, I've seen it, right? And so the failure of imagination, again, gets applied particularly to poor people. But the story is about a patient, going back to the patient-centered approach that you have advocated, and that would be informative for public health as well as clinical medicine. So this girl, her name is Mariatu, I heard about from a friend of mine. Again, there weren't local doctors, nurses, so of course we tried to bring, people said no one's ever going to volunteer to work on this. We had 1,500 people sign up via the website of Partners in Health to volunteer. So that was wrong. But again, it doesn't matter if you're wrong, it's about poor people. Right? You can say whatever you want. Spread by bushmeat, strange funerary practices. So we did have quite a few people sign up. One of them, I was in Haiti, an American emergency room physician. Last time I was here, I told you about the hospital that we were opening after the earthquake. We did open it, by the way. It's beautiful. It's the largest solar-powered hospital in the developing world, in central Haiti. Right? So Reagan Marsh is this young doctor's name. She had worked to start the first emergency medicine training program in Haiti. That's her, the blonde one. Mm-hmm. She was leaving Sierra Leone. I was in Haiti. I said, Reagan, you know, we really need your skills yesterday in Sierra Leone. I kind of just kidnapped her. Mm-hmm. And she didn't say no. The Haitians weren't happy with me because they loved working with her, but there already was a functioning emergency room in central Haiti with emergency room doctors. I just saw a Zika patient there, we think it was a patient with Zika, a little boy, 12 years old, who presented with quadriplegia in the middle of the night. Reagan's off in Sierra Leone at the time, but the emergency room attending, the senior physician, Haitian, she said, I think this boy needs to be intubated. They intubate him. He goes to the ICU. We have an ICU. You think there was an ICU there before the earthquake? Anywhere in rural Haiti? Well, there is now. This had nothing to do with any of us. The emergency room attending, a young woman, says we need to intubate him. She calls the ICU attending, another young woman, she intubates him. I see the kid 10 days later and they're asking me, is this Zika? I said, doesn't matter, you already saved him. He's extubated, tracheostomy. He doesn't walk out of the hospital, but he gets rolled out. I'm hoping to see him in a couple of days, actually. So that's Reagan. Reagan calls me and says, I'm sorry, I'm going to miss you tomorrow, but there's this girl I want you to see. She's an Ebola survivor. This is back to the whole person. But she hasn't said anything since she got discharged from the Ebola treatment unit, where we actually were trying to treat people. And she's dying of she's emaciated and dying of malnutrition, or who knows what. And some of the nurses thought maybe she was brain damaged. This is Sierra Leonean nurses. So I went to see her, and not very original, said, we have to have food in her, and she won't talk or eat, so we're going to have to put a nasogastric tube in, and did. And she looked at me with something that was not a pleasant emotion, but she didn't say anything. And then she just pulled it out and someone else put it in. And I had this guy that I told you about, Ibrahim, 26 years old, told me he lost 22 members of his family. Ever since that night, he had been telling me, this was Thanksgiving American time, so it would be the third week of November. He said, I want to help Ebola patients. I want, that's what I want to do. This was after he just got out of that horror and lost most of his family. And, it's not my decision really, but somehow I felt, kind of paternal. But paternalism gets a bad rap though. And I said to him, if I were you, that would be the last place I'd ever want to go again in my life, an Ebola treatment unit. And he was still sick and recovering, so I could ignore it. January, went back, he was still saying the same thing. He had joined the Ebola survivors group that Partners in Health sponsors, and that's what he wanted to do. He hadn't gone to high school. He was, he's had a really, and we were ambivalent about having survivors anywhere near patients, not because we didn't think they were immune, we did, but you know, you have to be careful about exposing people to any kind of risk, right? And he insisted in the third week of January 2015, as if I were his, he didn't, you know, he's lost both his parents by now, but he said, can I go with you to the Ebola treatment unit? This is one in the northern part of Sierra Leone. And I said, I asked a couple other people, what do you think? And, but anyway, he did go with me, and he went to see this child. I'd already been seeing her a couple of days. And we walked into the unit, and I was planning on paying close attention to him. You know, he had sequelae of disease, as many people do, not blindness, but clearly psychological distress and insomnia and some other neurological sequelae, and probably psychiatric ones as well. I mean, who wouldn't, right? And I was planning on paying attention to him. I told him about this little girl and said I would introduce them, because that's what he said he wanted to do, was communicate to Ebola patients. And she was certainly the least communicative one in that unit. She had been discharged to the local public hospital, and the whole pediatrics ward was only, I think everyone, all the kids in that ward had survived Ebola. And she was the only one who was completely uncommunicative. And he went over and sat down with her, and I said, this is Mariatu Ibrahim. She made no acknowledgement of what I said. And then, just then, another girl, I may get the age wrong, but youngish, I'm going to say 6, had a seizure. And there were no bed rails, which again, mistake, staff, space, and systems. And so I was the only health professional in the room, and she fell right off the bed and had a grand mal seizure. So it was really only out of the corner of my eye that I saw what happened next, because I was attending to her. Mariatu, this girl, took a hold of Ibrahim's shirt and pulled herself up to his ear and said something. And as I said, there's nothing I could do. I was trying to manage an emergency, calling for help, etc. And you know, an Ebola survivor, as some of you know, the viruses can be isolated in the urine for months, right? And of course, what happens when you have a seizure? And so I have to say, with some shame, I wasn't happy that I was drenched with urine. I was otherwise occupied, but I saw this happen. About an hour later, when things died down, unfortunately the patient didn't die, and she was okay. I went outside and I said to him, what did she say to you? And he said in a matter-of-fact voice, she told me I want this certain kind of juice and these cookies I really like. Now the nurses were saying, well, she might be brain damaged. She hasn't said a word. And I close with that story because social medicine is about understanding historical context. It is about understanding how poverty works in the world and how racism and discrimination and histories like the history of slavery are erased, shut down the oubliette, not even part of our discussion. It's also about listening to patients. And that's what he was able to do. That's Mariatu and Ibrahim before, and this is her after. Last anecdote, last line. Sometimes when I go back there, which is quite frequently, you know, well, not sometimes, but one time they said, oh, we have a surprise for you. This is not too long ago. And I knew it was going to be a survivor, you know, who I knew. It was Mariatu. And like, they bring her over, she sits on my lap, you know, and photo op. And I said to Mariatu, I know you didn't start school yet. All the schools in Sierra Leone were closed, but you're going to in fall. You know, when I come back, I'll bring you a nice present. You want some crayons or stuff to draw with? She said, I want an iPad. Thank you very much, and I look forward to our discussion.